Good afternoon, good evening. Welcome to our webinar, Radiation Trends and Developments. We're going to be talking about the key takeaways from the 2024 Astro meeting. So I'm thrilled to be here with you and welcome our guest speaker, Dr. Jonathan Leeman. My name is Shelby Monier, Vice President of Patient Programs and Education here at Zero, and I'm really excited to be serving as the webinar host today. Dr. Leeman, thank you for being here with us. We'll introduce Dr. Leeman in just one moment. Before we get started, just wanted to share a few notes. Our webinar is being recorded today, so it will be posted on our website, zerocancer.org, later in the week. And as soon as the webinar ends, this is my plug for our survey. Please take a moment, let us know what you thought about the event. And we also like to ask you for, the topics you want to hear about in the future. So that helps build our patient programs and education resources so that they are always meeting the needs of our patient and caregiver community. You are welcome to submit your questions at any time. And as soon as the webinar concludes and Dr. Leeman's presentation is over, we will get to as many questions as we can. So at any time, you can put those in the Q&A box at the bottom of your Zoom screen. So if you are new to Zero, I wanted to share just a bit about us. Zero Prostate Cancer is the leading national nonprofit with the mission to end prostate cancer and help all who are impacted. Zero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. At Zero, we have a variety of patient programs and support programs, educational tools, all of which are offered at no cost to the patients and families who need these services. So if you or someone you know is looking for resources at any time throughout the prostate cancer journey or experience, please reach out, please share these resources and let them know that they are not alone. So just quickly, our 0360 program is a wonderful comprehensive case management program that actually pairs patients with trained case managers. And that case manager can help you connect with financial assistance programs, navigate insurance, and find other kinds of support, including emotional support and transportation assistance. They can help with open enrollment. I know that's happening right now. So really, really, truly comprehensive in nature, wonderful program, very high touch, helps a lot of patients each year. We also offer 2 peer support programs. So one is our mentor program, which makes one-on-one connections. And then we have about 160 support groups throughout the country and a few international support groups that we offer both virtually and in person, led by our Zero support group leaders. If you like online support that's sort of 24/7, we have a couple of options for you. Zero Connect is our private group on Facebook. We also have a group on Inspire, which is an online patient forum that has about 40,000 community members. So a lot of places for you to get any of the support and networking and camaraderie that you might be looking for throughout this prostate cancer diagnosis of yours or your loved ones. So without further ado, I now get to pass it to Dr. Jonathan Leeman, Assistant Professor of Radiation Oncology at Harvard Medical School, Director of MRI-guided and Adaptive Radiotherapy at Dana-Farber Brigham Cancer Center. Dr. Leeman, thank you so much for being here. Dr. Leeman is also one of our brand new medical advisory board members at Zero. So really thrilled and honored that you are taking the time out of your very busy schedule to help with this webinar and share with us all of the interesting studies that came out of Astro this year.
Well, thank you very much, Shelby. Thanks for the introduction, and I'm thrilled to be here. I always love doing these presentations where I feel I can communicate directly with patients and with people who are affected by prostate cancer, and it's wonderful just to see so many attendees already here. I am a radiation oncologist, and I specialize in radiation treatments for prostate cancer. And today I wanted to highlight some of the really exciting findings that we learned about from this year's Astro conference. And so just a few disclosures. I do receive research funding from a few companies, including ViewRay, which is the developer of an MRI-guided radiation system that I will be discussing today in one of our sessions. So this year's Astro conference was in Washington, D.C. Astro, which is the American Society of Radiation Oncology, is our largest professional society in radiation oncology and our largest annual conference. There's usually around 10,000 attendees. And thousands of research projects that are presented. And so it's really difficult to pick the most important ones. I can't talk about all of the prostate cancer research that was presented this year, but I wanted to select a few, and I settled on 4 clinical trials that were presented this year at Astro that I'll go through one by one. And each of these are actually randomized clinical trials, which is sort of the highest level of evidence we have in clinical research to help us guide our practice and to help us make decisions about diagnostics and treatments for prostate cancer. And actually, each one of these presentations, each of the presenters was kind enough to share their slides with me so that I can thereby share them directly with all of you for the purposes of this presentation. So I'm very grateful for that. Now, I want to start out by talking about probably, one of the highest impact presentations from this year's conference, and it relates to proton beam therapy. And so many may be familiar with proton therapy, which is a form of radiation therapy that has certain physical advantages over standard types of photon radiation. In particular, it has the capability of delivering a radiation treatment to the prostate and other parts of the body with less what we might call scatter radiation or exit radiation. Essentially, the proton beam enters the body and then stops at a specified point, which is sometimes called a Bragg peak or a spread out Bragg peak. And beyond that point, there's actually no radiation that's delivered. And you compare that to X-ray radiation, where you see that as you get deeper into the body, the radiation is delivered to the tumor, but also goes beyond the tumor and delivers what we call exit dose. And so we can sometimes visualize this by looking at sort of a dose color map. And on the top here is an example of proton therapy, where there are 2 beams coming in from the sides. And you can see the red area is where the full radiation dose is being delivered to the prostate. And this greenish area is where there's lower dose of radiation. And you compare that to a photon radiation treatment, and this is something called IMRT, or intensity modulated radiation. And you can see there's just much more of this scatter low dose radiation outside of the prostate that's part of photon radiation. So there's this physical advantage, but proton beam therapy is really only available at limited centers. It's more expensive. And so the question for years and years has been, we have this treatment that seems to provide a more precise form of radiation, but what is the impact on people that are receiving this treatment? What is the side effect profile of proton therapy compared to a photon radiation treatment? So this was the basis for what's called the Particle trial. This was a phase 3 randomized trial of proton therapy versus IMRT for localized prostate cancer. This was led by one of my colleagues, Dr. Jason Evstathiou, and it was a trial conducted, as you can see, at many centers throughout the country that have proton therapy facilities who participated in this trial. So again, these slides are shared by Dr. Evstathiou and are from his original presentation. And so by way of introduction, again, patients with localized prostate cancer have several options, including photons or protons. Proton beam therapy, as I mentioned, has certain dosimetric advantages in terms of the precision of the radiation, but it's more resource intensive than IMRT or photon radiation. So the goal here was to address the hypothesis that proton beam therapy results in improved patient-reported outcomes. And this was conducted as a multi-center phase 3 randomized trial comparing the 2 modalities. And so the study design, 450 men were included and were randomized to either proton beam therapy or intensity modulated radiation therapy. And again, these were people with localized prostate cancer. The primary endpoint that was being studied was bowel function at 24 months after radiation treatment using a standard questionnaire that's known as the EPIC questionnaire. Then a number of other secondary outcomes were looked at: urinary function, erectile function, other types of biomarkers and outcomes. And so I like this slide because it highlights how substantial of an endeavor this trial was. You can see that this trial was first activated in June of 2012. And that was after several years of designing the trial, getting the trial up and running, getting it approved by different committees. It was finally opened in 2012, and it didn't actually report the first results until a couple of weeks ago in 2024. So 12 years from the time the clinical trial actually opened to when we have the results of the primary endpoint. And you can also see along the way all of the different centers who joined into this trial and sort of all of the changes in clinical practice that occurred throughout this time. This is the patient accrual. In other words, how many patients enrolled in this study over time. And you can see in black, it was pretty steady. There was a little bit of a slowing after the COVID-19 pandemic, but really they ended up exactly where they wanted to be in terms of accrual in 2021. Looking at the types of people who were enrolled in this trial, you can see the average age was 68. About 80% of the patients were white, 20% being black or other races. And most of these patients had what we call intermediate risk prostate cancer. About half received rectal spacers. About half were treated with what's called hypofractionation, or sort of shorter courses of radiation. And about half of patients on the proton therapy arm were treated with something called pencil beam scanning, which is sort of a modality for using proton treatment. And this is the primary endpoint. So this is looking at quality of life. So these are questionnaires filled out by patients who were treated as part of this study. And what were their bowel-related symptoms at different time points after radiation? The blue being IMRT or photon radiation, and the purple being proton beam radiation. So what we're looking at on the y-axis here is the bowel score, 100 meaning no bowel issues whatsoever, and 0 meaning obviously substantial bowel problems. And then we're looking at the time following treatment and randomization. What you can see is that there's maybe a small decrease at the sort of initial period after radiation, and then this stabilizes. But the important thing is that there's no appreciable difference between proton beam therapy and photon therapy, looking at bowel quality of life. So this was the primary endpoint of the study. And then zooming in, this is the same data, just zoomed in, and you can see these error bars all overlapping. No statistical difference between these treatments. They looked at many other outcomes aside from bowel effects. They looked at urinary incontinence, no difference. They looked at urinary irritation, no difference. They looked at sexual function, no difference. They looked at biochemical and clinical failure. How many patients developed recurrences within 5 years after treatment? Fortunately, only about 5% of men overall developed any recurrence, but there was no difference between the treatments, whether it was photon or proton radiation. This is biochemical failure-free survival alone, progression-free survival, different ways of looking at recurrence risk, and no difference between these arms. They looked at different age groups, age under 65 or over 65. Within those groups, no difference. They looked at intermediate risk prostate cancer versus low risk, no difference. Rectal spacer use, no difference. And this goes on and on. Fractionation schedule, no different. And so, as you can see, the takeaway here, and I'll try to summarize, each trial with a few bullet point takeaways. Either proton or photon radiotherapy seems to provide excellent outcomes in terms of cure rate and side effect profile for the low and intermediate risk groups studied in the particle trial. The particle study did not seem to demonstrate any clear advantage of proton treatment over photon treatment for prostate cancer. I would say, however, that proton therapy still does need to be studied further. There may still be important benefits for certain patients. For instance, people who are getting radiation a second time, where precision is even more important, or people who are getting radiation to the pelvic lymph nodes in addition to the prostate, which is something we're doing routinely now for high-risk prostate cancer. These are situations that still need to be studied, and we still need to know whether there's a benefit for proton therapy. And then there are still additional questions that remain. You know, we've only looked 5 years out, but we know with prostate cancer, this is a marathon, not a sprint, and things can happen 10 years, even 15 years later in terms of recurrences and in terms of side effects from radiation. So we need to see actually more long-term data. And one thing in particular I'm interested in seeing is whether proton therapy impacts radiation-induced cancers. We know that with radiation therapy, there's a small risk of actually inducing a cancer with our treatment. Those are cancers that tend to develop many years after radiation, even decades later. And so it's too early at 5 years to know whether there's a difference. But, you know, there is, you know, theory that says that the lower doses of radiation and the more scatter or exit dose may be responsible for some of these radiation-induced cancers. So that is important information that still remains to be seen. So I'll move on to the next study, and this relates to MRI-guided radiotherapy. And what is MRI-guided radiotherapy? This is essentially a technology that is an MRI scanner that's integrated with a radiation delivery system in one machine, one device. You can see this is what the device looks like, at least at our department at Dana-Farber Brigham Cancer Center in Boston, where we have one of these MRI-guided radiation systems. The benefit here is that the system can acquire MRI images immediately before and during treatment to more precisely align our radiation. It also allows us to do something called adaptive radiation, where we can make adjustments every day depending on day-to-day changes in anatomy and account for unexpected motion. So this is a more advanced, more technically involved, fancier way to give radiation, more expensive as well. The question becomes, similar to what we just talked about with proton therapy, does MRI-guided radiotherapy improve the side effect profile of radiation treatment? And here's just an example of MRI-guided radiation. This is a video which we'll see if it'll play. Oh, let me go back. May or may not let me play it. Essentially, what it's meant to show is the way we can monitor the prostate during radiation and the way that we can track the location of the prostate as we're delivering the treatment. And if anything moves, the MRI video feed can capture that and turn off the radiation system as a safety mechanism. So this was the Mirage trial, which was a randomized trial of MRI-guided versus CT or computed tomography-guided stereotactic radiation therapy for prostate cancer. These are 2-year outcomes. This was a trial done at UCLA, and these results were presented by Dr. Amar Kishan, who again was kind enough to share slides for this presentation. And so, again, the theoretical benefits of MRI-guided prostate radiotherapy is that we can reduce what we call our PTV margins, which means we can treat a smaller area around the prostate because we have less uncertainty about motion and about day-to-day change. So we can be more circumscribed with our radiation treatment. There's also other potential benefits of using MRI during the treatment. We may be able to see the urethra better and control the amount of radiation that goes to the urethra to avoid side effects. And actually with MRI-guided radiation, we don't need to implant fiducial markers. We don't need added X-ray radiation that is delivered from what's called IGRT or image-guided radiation. And so again, this was a trial looking at what we call margin reduction. So the uncertainty margin was reduced from 4 millimeters to 2 millimeters, essentially a smaller, more precise treatment with MRI-guided radiation. 156 patients were treated, and this was done between May 2020 and October 2021. Some of these results have previously been presented in terms of the short-term toxicity. The update here was really to have toxicity side effect results 2 years out, which is important because the short-term side effects are one thing, but we really want to know how people are doing years after radiation treatment. And this is the key slide, and these are called cumulative incidence curves. What we're looking at again is sort of time on the x-axis, time after radiation treatment, and on the y-axis, the likelihood of an event occurring. And in this situation, what we're talking about is grade 2 urinary events. So these are urinary side effects, people needing medications to help with urinary symptoms. And at 2 years, 24 months, the risk of that was 27% with MRI-guided radiation, 51% with CT-guided radiation, which was significantly less when MRI guidance was used. And a similar finding when we look at GI side effects or gastrointestinal bowel issues. Low rates in both arms, 9% versus 1.4% at 2 years, but significantly lower in the MRI treatment arm. I won't go through all of this in detail, but these are a number of quality of life surveys that were done and showing that risks of people reporting issues with urinary incontinence here were smaller with MRI-guided treatment, and the proportion of people reporting issues again with bowel were smaller with MRI-guided treatment. And again, looking at other outcomes, other patient-reported outcomes, bowel side effects, the odds ratio of 0.44, meaning lower risk of bowel issues in the MRI group. And then the SHIM questionnaire is related to erectile function. And there's actually some suggestion that erectile function may be better in the patients who received MRI-guided radiation. That is sort of exploratory. I think it really remains to be studied further, but it's an interesting thing to see nonetheless. And so the takeaways for this study: MRI-guided radiotherapy is a promising new technique that may reduce certain side effects of prostate radiation, urinary, bowel, or sexual side effects within the first 2 years of treatment. This does still need to be studied further. The Mirage trial was a small clinical trial, relatively about 150 patients, and it was done at a single center. So it always raises the question, is this generalizable to the general population if this was just done in one hospital? Usually, before we change practice and standard of care, we want a larger trial that's been conducted at multiple centers, and we consider more generalizable to the general population. One of the questions this trial has raised is it remains a little bit unclear whether it's the technology itself, whether it's the machine, or whether it's the technique, and this is getting into some of the nuance, whether it's actually the technology of the machine or whether it's the smaller volume that was, treated in the MRI treatment arm that resulted in fewer side effects. And my opinion, it may be both. It may be that the technology of MRI guidance is what allows us to be more precise with treatment. And so this was exciting to see. I think this is a promising area where we're seeing improvements in the side effect profile of prostate radiation with new technology. Okay. I'll move on next to talk about hypofractionated radiation treatment. I sort of alluded to this, but multiple clinical trials now over the last 10 or 20 years have looked at what we call hypofractionated radiation, which means shorter, more condensed courses of radiotherapy. And so in this table, you can see some of the different schedules and types of radiation treatment. Historically, prostate radiation was done with conventional fractionation, as we call it, which means giving about 40 treatments every day over the course of 8 or 9 weeks, which you can imagine is, and many of you know, is highly inconvenient, disruptive, and just a major commitment for people who are undertaking this type of cancer treatment. So there's been a lot of interest in shortening these radiation treatments or condensing them. And we want to know if that's as safe and as effective. And so moderate hypofractionation has generally been looking at shortening these courses from 8 or 9 weeks down to 4 or 5 weeks, 4 to 6 weeks, I should say. And then there's SBRT, or stereotactic body radiation, which is sometimes called ultra hypofractionation, which is looking at just 5 treatments, generally done over the course of 1 to 2 weeks. These are sort of the different categories of prostate radiation scheduled. Now, these trials that have looked at hypofractionation, particularly moderate hypofractionation, have generally shown equivalent efficacy and side effects for certain types of patients getting prostate radiation. But we want to know, again, in the long term, what are the patient-reported outcomes? What are the patients saying who have received these treatments in terms of their questionnaires, their quality of life, the side effect profile of the treatment years after the treatment? And so this is the PROPHET trial, as it's called. And this was a quality of life analysis in patients enrolled in the PROPHET trial, which was comparing moderately hypofractionated radiation to conventional radiation for intermediate risk prostate cancer. And again, Dr. San Mehmed Salgado did share her slides for this presentation. So this trial included actually 1,206 patients with intermediate risk prostate cancer, so a large trial. And they were randomized to receive either 8 weeks of treatment or 4 weeks of treatment. And what was looked at here was, again, patient-reported outcomes. So these were questionnaires that patients filled out at various time points before, during, and after the radiation treatment, looking at what's called health-related quality of life. That's the acronym there. And just to cut to the results, looking at urinary symptoms, this is a commonly used questionnaire called the AUA symptom score. When you look at baseline at 0 months, 24 months, 48 months, no difference between whether patients got conventionally fractionated radiation or hypofractionated radiation. This is very encouraging because it's one of the concerns with shortening or condensing the radiation treatment, that we could be causing long-term or chronic or later urinary problems that don't manifest immediately but can crop up years later. And looking 4 years out, at least, that didn't seem to be the case. So this is very reassuring for people who are interested in shorter courses of radiation, that at least in this trial, it looked like 4 years out, there was no difference in urinary questionnaire score. And then the EPIC questionnaire, which I mentioned previously, is commonly used, that looks at different sort of domains, different types of symptoms that can occur with prostate radiation. So urinary changes were no different. Bowel changes were no different. Sexual changes, no different. And hormonal changes, no different. So all very reassuring. There was this one interesting finding where they did find on the bowel questionnaire that actually the people who received hypofractionated radiation seemed to have lower risk of bowel problems that they were reporting 48 months after the treatment, which is interesting. It's not something we've seen in other trials. I think that needs to be explored a little bit further. But I think the main thing is it's very encouraging, again, to see that the hypofractionated treatment is not worse, that we're not paying a big price by shortening and condensing the radiation from 8 or 9 weeks down to 4 weeks, as was done in this trial. And so the takeaways here: moderately hypofractionated prostate radiation in 20 sessions. It's been previously shown to have similar efficacy to longer course radiation. This update demonstrates that patient-reported outcomes are favorable even 4 years after radiation done in 20 sessions. And clinical trials of shorter radiation courses, I would say, are broadly demonstrating equivalence and are more convenient, more cost-effective, and increasingly becoming standard of care. So anybody who's embarking on prostate radiation or looking into it, this is something that's important to ask about and explore, because there's a major difference in terms of the experience of going through radiation for 8 or 9 weeks versus just 4 weeks, or maybe even shorter with a treatment like SBRT. This is good news for patients everywhere. The last presentation I'll mention relates to imaging for prostate cancer, and specifically related to PSMA PET scans. PSMA PET scans are a relatively new imaging technique. They've been around now for several years, increasingly entering practice. And the idea is that they can identify areas of prostate cancer throughout the body in a way that's more sensitive and more specific than other tests that are that have historically been used to image for prostate cancer, like CAT scans or bone scans. The way this works is a substance called a tracer is injected intravenously, and it actually binds directly to a molecule on the surface of prostate cancer cells and sort of causes them to light up on these scans so that we can more clearly visualize them. And so this is an example of a PSMA PET scan looking in the pelvis and showing this bright area. This is the bottom left panel where there's a lymph node in the pelvis that's identified, that's small and may not have otherwise really have been detected with other imaging techniques. In the bottom right panel, this is another example of a PSMA PET scan where we are seeing activity or uptake, as it's sometimes called, in the prostate bed after somebody's had prostate surgery. And so this is very helpful for us to know so that we can guide our treatment, so that we can use more targeted radiation. And so PSMA PET CT has increasingly been used for staging of prostate cancer. In other words, when somebody's first diagnosed, getting the scan and making sure that there's no spread of prostate cancer anywhere else in a very sensitive way. This is recommended particularly for people with high risk prostate cancer. It's also very valuable after surgery if somebody has a rising PSA after surgery to try to detect where the recurrence may be. And that again can help guide radiation treatment. But the question arises, it can help guide our treatment. We make decisions based on the PET CT findings, but how are we actually impacting patients with these scans? Does getting a PET CT and adjusting our radiation field or our treatment accordingly, does that actually help people in the long run? Or are we just being more circumscribed with our treatments, but it's not making a clinical difference? That's an important question. And we want to know if these scans, which seem valuable, are actually having a meaningful and measurable difference in the patient experience or in disease control. So that was the basis for this trial. And so this was a trial that was done in Montreal. And Dr. Beliveau shared these slides with me. And this was a trial of PSMA PET guided intensification of salvage radiation after radical prostatectomy, a phase 2 randomized controlled trial. And so again, this sort of summarizes it. There's a change in management, but does it impact the outcomes or the patient experience? So we can get these PET scans and it improves detection of prostate cancer. And that can lead to a change in management, a change in how we deliver radiation, change in how we target it, whether we even give radiation at all. Does that ultimately have an impact on the patient in a positive way? And so this trial was meant to determine if PSMA PET guided intensification of radiation would improve what's called failure-free survival or preventing recurrences. And so this slide sort of summarizes what was done in the trial between the two different arms. One is, the standard of care salvage radiation, where a radiation treatment is directed at what we call the prostate bed, or the area where the prostate and seminal vesicles prior to surgery. And this is kind of the appearance of a standard salvage radiation field. The experimental arm incorporated the use of the PET CT scan to identify any areas of activity and adjust the radiation treatment accordingly. And so this is PSMA PET with intensified salvage radiation. And so what the example you see here is that the PET scan picked up a small lymph node in the pelvis, and the radiation field was adjusted to include it and to give that lymph node actually what's called a boost dose or a higher dose. The question is this helping? And so when we look at failure-free survival at follow-up 3 years out from radiation treatment, we do see a significant difference in patients who had recurrences. 10 subjects or patients who underwent PSMA scan and adjusted radiation plan accordingly versus 20 in the control arm, so about half. And so this was statistically significant, showing that incorporation of the PSMA PET scan seemed to actually reduce the risk of recurrence. And when they looked at where these recurrences occurred, a lot of them were what's called locoregional, and that means essentially around the area where the prostate was, the prostate bed in the pelvis. And so these were patients who seemed to benefit from the incorporation of PSMA and the use of this more advanced imaging. They looked at another endpoint, which was what they called treatment-free survival. In other words, how likely is it that somebody would need to go on to another form of therapy after having radiation? How likely is it that they would need to have hormone therapy or metastasis-directed radiation? And what they saw is with the use of PSMA and the better targeting, the better delineation, the better detection of prostate cancer, fewer men needed to go on to have hormone therapy or additional radiation treatment, which is very exciting to see. They looked at different subgroups of the population that was studied. They did see that there seemed to be more benefit among people who had higher PSAs, so a PSA above 0.3 after radical prostatectomy, after surgery. Those patients seem to have the most benefit from having a PSMA scan, which is not surprising. What we know about these scans is that the higher the PSA is, the more likely we are to detect something, the more likely we are to pick up what the source of that PSA is or some activity on the scan. And so this makes sense that people who had higher PSAs were more likely to have a benefit from having these PET scans. The takeaway here is that PSMA PET CT is a valuable imaging test for detecting areas of recurrence after prostate surgery. Incorporating PSMA PET CT into the radiation planning process, particularly what they looked at here was when radiation was being given after surgery, may help to improve the targeting and the success of the radiation treatment. So that's all I was going to cover today. I think the theme here is we are looking at new technologies. So we talked about proton therapy, we talked about MRI-guided radiation, talked about new imaging like PSMA PET scan. And these are clinical trials. This is clinical research that is studying, are these new tools making a difference for people? Are they helping either cure prostate cancer or improve the quality of life and reduce the side effects of prostate cancer treatment? And so these clinical trials, particularly randomized controlled trials, tend to be the ones that change our practice and provide the highest level of evidence. And so these were some of the, I thought, most impactful presentations related to prostate cancer that were presented at Astro this year. And it was exciting to see some really encouraging results and questions answered that we've been thinking about for many years now, in particular related to proton therapy, which was one of the highlights. And so I will stop there. Thank you for your time and your attention, and happy to take any questions.
Great. Thanks, Dr. Leeman. We do have some questions. I know we are not surprised. We're thrilled. Thank you all for typing these questions in, and we'll get to as many as we can. I'll try to go probably just in order of arrival. So I apologize for some of the bouncing around. So this attendee is wondering about just kind of the general, I think, dosage of radiation and exposure, and whether or not that leads to more damage to healthy cells just on the way to reach the prostate cells.
Yep, that's a great question, and that sort of forms the basis for proton therapy, and the hypothesis that it could improve the treatment because you're basically delivering less radiation sort of on the way and on the way out as the radiation beam enters and exits the body. And so that's the theory, that leads to speculation that it may reduce side effects. But we need the clinical evidence to really know. And we need these large clinical trials. And the particle trial was very well conducted, a very rigorous trial. And the results of that trial, at least, were, didn't seem to show at 5 years any significant advantage to proton therapy over photon radiation. Again, this still needs to be studied further, but that was the outcome of the particle trial at this presentation.
Thank you. This individual recently completed SBRT treatments and is wondering just the general difference between that and proton therapy.
Yes, so SBRT, or stereotactic body radiation therapy, that refers to a technique for delivering radiation where it's done in fewer sessions, most commonly 5 radiation treatments instead of, 4 weeks, 6 weeks, 8, 9 weeks. So it's a shorter, more condensed course of radiation, 5 sessions. And that's made possible by technology and by higher precision of the tools that we use to give radiation, like the image guidance. So stereotactic body radiation refers to this sort of schedule of shorter treatment and higher precision using imaging. Proton therapy is a specific form of radiotherapy that is where a charged particle called a proton is delivered instead of an X-ray or a photon. It's actually a different form of radiation entirely, and it works in different ways. And these proton treatments are currently only available at some centers. It's less widely available. And it's always begged the question, does it need to be done for prostate cancer? What are the advantages? Where does it fit in? And so SBRT can be given with either photon or proton radiation. Those are just sort of different physical methods for delivering the treatment. Hopefully that helps answer it.
Great, thank you. The next question is, are you familiar with HDRBT used for prostate cancer and metastatic nodules in other organs, i.e. lungs? And would love your thoughts on that.
Yes, so HDRBT, likely referring to high dose rate brachytherapy. And so that's another form of radiation, which I actually didn't even get into today, though there were some presentations about it at Astro, where radiation is delivered internally, usually by implanting radioactive seeds or in the form of high dose rate, inserting catheters and delivering a radiation source directly into the target or the tumor. And this has been very successful in prostate cancer radiation and been well studied, and is a very effective treatment for prostate radiation. I would say there's less evidence to support its use in other parts of the body where there may be metastases from prostate cancer, if that's the question. More often when somebody has a metastasis from prostate cancer that we want to treat with a high dose of radiation, more often we'll use something called SBRT, or stereotactic radiation, which is external beam radiation in a few sessions. So there may be a role, depending on the situation, for brachytherapy, for instance, in a lung nodule. That's not as commonly done, though, as something like SBRT.
Great. Thank you. And this question is kind of more generally speaking, not so much about one of the presentations that you covered, but just kind of high level. This person is wondering just what form of radiation therapy is best to treat prostate cancer that is confined to the prostate, and located in, just in one area of the prostate.
Yep. So that's the $1 million question. And I wish there was one answer. It would make everybody's life more simple. But fortunately, we do have many good options. And so there are different ways to deliver prostate radiation. And some of them I touched on today: photon radiation, or IMRT, proton radiation, stereotactic radiation, brachytherapy. All of these have their pros and cons. It's sort of an individualized choice. And a lot of it also comes down to the individual characteristics of the person and their cancer, their anatomy. What does the prostate look like on an MRI? How big is it? Do they have any symptoms at the outset, urinary symptoms, that might make us need to be more gentle with the radiation treatment? Is the prostate cancer located in a spot within the prostate that's amenable to brachytherapy or doing internal radiation? It's a very individualized and nuanced treatment. Prostate cancer radiation has gotten very complicated over the last 5, 10 years as more technology and more of these approaches have come about. And it's a blessing and a curse because we have all of these options, which are doing better things for many people, but making the decision can be really difficult. The best advice I have is to speak to a radiation oncologist and maybe look at another opinion to make sure that all of the options are being described to you. And it's good that somebody like you who's here doing your own research to learn about it. Um, that always helps as well. And so it's an individualized choice.
No, I love that answer. We don't we try to, but we can always talk more about the importance of seeing an expert, but also of getting a second opinion. And that's not a, an insult to your healthcare team. But the benefits of having more eyes on your case, and more opinions is, it's a good thing, and it's not an insult,
I
to
think
your
that's right.
provider.
Yeah.
Yeah, so thanks for mentioning that. The next question is, X-ray machines are expensive enough, and I have to assume that MRI machines, will be even more expensive. So is it going to break the bank, to change over into these more expensive machines?
So I'm very glad that question was raised. This is an area of my particular interest because I'm interested in new technologies for radiation. And you're absolutely right. It's getting very expensive. And the question becomes, does the added cost justify any benefit? And that's why these clinical trials are so important for us to know, is all of the investment, all of the cost that's going into this, is it making a difference for people? And if it is, great. Then we should really look at that and find ways to make it cheaper, find ways to make it more accessible, and focus on that. If it's not, then maybe we look at, we move on and look at other technology. But I think the clinical data is so important in making decisions about where we should invest our resources and our efforts in terms of technology. I will say that, many of these devices like MRI guided radiation, this is something so new. And these first iterations absolutely are extremely expensive. But my hope and what I would envision is that over time, if this is proven to be beneficial, it will get cheaper and the technology will get more accessible. These are really just the first steps and almost prototypes in a way of new ways of giving radiation. So it's a really important question for our healthcare system.
Thank you. The next question, I'm keeping an eye on the clock. We're okay right now. What is typical and concerning, regarding side effects of urinary, irritation? So maybe not so much incontinence, but this patient is, or I'm assuming a patient, regarding burning after prostate seed implants.
Yep, yep. So what I'll say is, that is one of the most common side effects of prostate radiation. The prostate gets and the urethra, they get irritated or inflamed, and it's a very common issue that develops after prostate radiation. Most of the time, it's what we call an acute finding, which means it happens in the short term and then gets better, but not always. I would say it's always something you should talk to your doctor about. It may be normal, and it may be something that will get better gradually over time. But it's always good to address these things earlier. And you also want to make sure you're not missing anything. There can be urinary tract infections, for instance, that, we can think look like side effects of radiation, but there's actually an infection going on. So usually I suggest talking to your doctor about it and seeing if there's any additional testing that needs to be done.
Yeah, you bring up a good point just in general about reporting side effects to your treatment team. This is my question. So I'm sneaking one in. But have you found that there is some hesitancy with the patient community in reporting side effects for perhaps fear of being taken off treatment or having to switch treatments?
Yeah, I think there are many reasons why people don't report side effects. One, they may think it's normal and they may think there's nothing to be done about it and they just have to live with it. They may be embarrassed. It's normal for people to be embarrassed talking about, some of these issues. especially when it relates to sexuality and that type of thing. But these are conversations that we're expecting to have as providers and as caregivers, and we want you to bring them up. And so I do think there's often reluctance, but I would just encourage people to have a low threshold for raising these questions with their care team, because really the goal is to make it easier for you. And oftentimes you may think there's nothing to be done about it, but there may be something that could really help you and make your life better.
Yeah, thank you. The next question is a person wondering, what is the long-term efficacy of SBRT, and in parentheses, whack-a-mole or spot welding on oligometastatic disease?
Yeah. So I didn't get into this today, but this is another, very active area of research and interest in radiation oncology, which is this idea of giving spot treatments to areas of metastasis in metastatic prostate cancer. And there have been several trials now that have suggested that there seems to be a benefit there in terms of slowing the prostate cancer down, making it a longer period until the prostate cancer comes back, and ultimately, hopefully, reducing the risk of dying from prostate cancer. That has not been demonstrated as much as we'd like, honestly. And so I think there's still active debate in our field and active research that needs to be done and that's ongoing to look at this approach, because there are risks with any radiation treatment, especially some of these higher dose treatments. We want to be sure that we're making a difference. A lot of clinical trials are directed at this topic, and so I think we're going to know more in the coming years. At the present time, though, it is something that, the data, the current evidence suggests should be at least explored, which is if you have something called oligometastatic prostate cancer, where it's prostate cancer that's spread to just a few areas, which we usually define as 1 to 5 areas, that you should ask about radiation treatment to these other areas, because sometimes what we see is that when somebody is diagnosed with metastatic prostate cancer, they're told it's incurable and that there are limited treatment options, and radiation is sometimes taken off the table. But we're learning more and more, actually, that radiation seems to be beneficial. New evidence has shown that actually treating the prostate with radiation for people who have metastatic prostate cancer seems to prolong survival and help people live longer and prevent side effects down the line. So there's a real emerging role for radiation in people with what's called oligometastatic prostate cancer, and it's an important topic. I'm glad that was brought up.
Yeah, a lot of great questions. A lot more we're not going to get to, unfortunately, but we have just a handful of more minutes, so we'll keep on going down our list. The next question. Should PSMA PET CT be used routinely after X-ray treatment to see if treatment was actually successful, or see if things are no longer lighting up?
Yeah, that's a good question. These are all very good questions.
We have a smart
A
community,
lot of
don't we?
smart, very well educated people here.
Yeah.
Who have done their research, and so generally after prostate radiation, um, the main marker that we use to determine how well the treatment has worked is the PSA blood test. And historically, that's been actually very reliable and a very good indicator in most cases of whether there's any active prostate cancer. And usually the PSA going up on several measurements, or going up by 2 points from its lowest value, that's an indication that there may be something going on. There may be a recurrence. Whether to get a PSMA scan if the PSA is looking good, there's uncertain value there. And I say that because oftentimes when we get a PSMA scan after radiation, you can still see activity in the prostate. And it may not be cancer, and probably most of the time it's not active cancer. It might be what we call treatment effect or inflammation. And that can sometimes lead to a lot of questions, a lot of anxiety, a lot of uncertainty, maybe more tests like biopsies that can have risks and be uncomfortable. And so generally for somebody who has prostate cancer localized treated with radiation, I don't recommend PSMA scans routinely in follow-up as long as the PSA is looking good. If the PSA is going up or doing something that we're concerned about, then I wholeheartedly support it. But I usually use the PSA as a first guide.
Thank you. So a little bit more on the PSMA. If the PSMA scan shows no spread of prostate cancer, when is salvage treatment generally appropriate?
Yep, another very good question. And so this relates to people who've had prostate surgery and have a detectable PSA after the surgery, which suggests that there may be some residual or recurrent prostate cancer. Generally, we recommend initiating salvage treatment when the PSA gets to a value of zero point 0.2. That's kind of a standard definition that's often used. Sometimes we'll even do it at lower values like zero point 0.1 if it's clear that the PSA is steadily increasing. The issue is that the PSMA scans often don't pick up areas of recurrence when the PSA is so low, like zero point 0.1 or zero point 0.2. And so we still think, at least I still think, it's important to have salvage radiation, even if the PSMA scan doesn't show anything. Because what we know about salvage radiation is that the lower the PSA is, the more effective it is, the more likely it is to cure the prostate cancer. And it really is the best chance for cure after somebody's had prostate surgery if there's a rising PSA.
Mhm.
So this is another area where there's some debate in our field, but I generally think that initiating the salvage treatment at a low PSA, even if the PSMA scan doesn't show anything, is the right thing to do. Hopefully that addressed the question.
Yeah, great. Thank you. So this one came in about the halfway mark, so it was probably in reference to the second or third. So hypofractionated study, do the favorable results apply to radiation as a secondary treatment? So post prostatectomy, either adjuvant or salvage, as well as radiation as a primary treatment.
Yeah, so the study I presented today and most of the trials of hypofractionation relate to somebody who has an intact prostate. We're treating the prostate itself with radiation. There are ongoing trials looking at hypofractionation in the post-prostatectomy situation after surgery. That data, those trials are less mature. I think that remains a little less certain. I think many of us want to see longer follow-up before really committing to shorter courses of radiation after surgery. You have to be very careful in that situation because you're giving radiation to an area where somebody had an operation. It can be very sensitive. We want to make sure we're not causing problems and we're giving a safe treatment. So there's more work to be done there.
Yeah. Thank you. And final question, I apologize we have a lot of questions remaining and I apologize for not being able to get to all of them. The final question that we're going to have time for is how all of these results, and you can kind of be general if you'd like, however you want to answer, vary based on a person's prostate size. So this person has an enlarged prostate and wondering if any of these results are varied due to in that
Yep.
case.
Yep, that's a great question. Prostate size is a really important variable that we take into account when we're thinking about treatment decisions. Sometimes if somebody's got a very large prostate and urinary problems from a large prostate and they have prostate cancer, that may actually guide us more towards recommending surgery as opposed to radiation, because sometimes you can address both problems with one treatment. You remove the prostate, so you remove the cancer, but you also remove the obstruction of a large prostate. So that's one aspect. But for people who are having radiation and have an enlarged prostate, you know, it does mean that there is some increased risk of causing side effects with the treatment because we're treating a larger area and the prostate can get more swollen and more affected by the radiation, more urinary side effects in particular. And so a larger prostate, we have to be more careful about condensing the treatment. We have to be more careful about hypofractionation, more careful about SBRT. When people have very enlarged prostates, sometimes we'll even recommend still doing conventional 9 weeks of treatment because it's maybe the safest in that situation. So that's an important factor that really does play into how we think about the schedule of the radiation and the intensity.
Right.
Good question.
Thank you. Well, thank you to all of our attendees. Thank you, Dr. Leeman, for such a great discussion and overview of the annual meeting. Can't thank you enough for being here with us. Your very first Zero webinar, first of we hope many. But thank you so much. And as we close our webinar, just a reminder, please fill out when you are removed from the webinar. The survey will pop up, so please be on look out for that, as well as the recording for the webinar from today will be sent out via email and posted on our website. So with that, again, thanks, Dr. Leeman, so much. Appreciate you very much. And thanks everyone for joining us. I hope you have a great rest of your day.